Hello, this is the NICU Lived Network, and we are your hosts. I'm Melinda.
I'm Nat.
And I'm Emma. We are all NICU mothers using our lived experience to partner with health professionals to impact research, advocacy, and clinical practice.
Each week we will bring you something new. It could be a topic highlight, the latest in research, a visit to a NICU, or ways in which you can use your lived experience within the NICU to impact change. We hope you enjoy this episode.
Well, hello, we are live. Hi, everyone. Nat is meant to be joining us, but we'll see if she's able to get on. So for those, and I know that we've got a little bit of a new audience that will be joining us today. My name's Melinda. I am the mum of 3 beautiful boys who were all born early and spent time in the NICU. My first son, Elijah, was born at 34 weeks. I had then Dylan at 27 weeks. And then with Jasper, had a cervical stitch at 12 weeks, but then also had to spend 14 weeks on bed rest, being able to then get him to 37 weeks. So a big, long time journey, but that experience has really led to, I guess, a whole different shift in where my life went in terms of wanting to be able to give back and help other families who have gone through that. So very, very special today. I am joined by Dr. Brett Manley, who is a neonatologist, and some of you may have been your baby's under his care at the Royal Women's Hospital in Melbourne, and he's also an associate professor and a researcher with the University of Melbourne. Hello, hey Brett.
Hi Melinda, what a thrill it is to be here.
Yeah.
And happy International Clinical Trials Day. It's a special day for those of us who spend a lot of our time undertaking clinical trials, but it's extra special to be here with you because I think all clinical trialists, especially in the perinatal neonatal field, would say how amazing it is that families and parents give so generously to us to help us undertake these really important clinical trials. So a big thank you to all of you out there.
Yeah, no, absolutely. So this live, we were basically just talking yesterday, just after lunch, and having a really great chat. And we thought, you know what, why don't we just continue this conversation tomorrow? Today is International Clinical Trials Day, as you've mentioned. Why don't we get on and just have a chat and bring people into the conversation? So thank you so much. I wanted to start with a question that I was asked when I was promoting that we
Oh, this is not good. We need a host. Just give her a second and see if she's back. Whilst we're waiting, I think what Melinda was about to say was that she's been having some questions. Oh, you're back. I was going to just go ahead without you.
What happened?
I was about to say, what's a clinical trial? Because I think that's one of the questions that had come through to you. And I think this is really important to kick off, that everyone understands what we're talking about. Because I think when a lot of people think about research or studies, what they think about someone in a laboratory or in a white coat wearing goggles or, crunching numbers and doing maths. But I think there's a whole other research world out there that people might not be aware of. And I'm not for a second saying that laboratory research, preclinical or research done in other formats isn't critically important, because it absolutely is. But clinical trials refer to studies or trials done in humans. And I guess what we're talking about mothers and babies, either mums at risk of premature birth, their premature babies, or mums or babies that are unwell for other reasons who may be born at preterm or term. And clinical trials are those carried out in babies and mothers, that means. And there's a whole range of what sort of clinical trials there can be. For example, a clinical trial would include just simply collecting information about mothers and babies and finding out what happens to certain populations of mums or bubs, or trying to find out whether some treatments seem to work better because some babies got them and some didn't. Right through to something that I'm really passionate about, which are randomized controlled trials or randomized clinical trials, where we actually undertake some intervention or some treatment in half of the mothers or babies and compare that to the other half of mothers and babies that didn't get that intervention or treatment, which is a really high level of evidence and a really good way of proving whether something works and is safe.
And so one of the questions I was asked is, what's the difference? Because the words interchangeable between a trial, study, doing research? How does a parent navigate between, like, is there any difference between those words?
Yes and no. They are used interchangeably. I guess the word trial in itself is usually referring to a clinical trial, although it doesn't always have to. So it's usually referring to a study happening in humans, in mothers or babies. Research can be anything across the entire sphere of what is research. It could be, in a lab looking at cells. It could be doing epidemiological research. We've all become really familiar with the term epidemiology or epidemiologist during the COVID pandemic. And this was the study of data, looking at what happened in populations of people. Again, right through to all types of clinical trials. So research can be anything. Trial usually means clinical trial in humans, not always, but I agree it's really confusing. And I guess as the research community, we need to get a little bit better in explaining what we mean.
Yeah. So I know from, if I use my personal experience, so talking about, like I mentioned, I'm the mum of 3 boys that were born early, particularly, and I spent a long time in NICU. With Dylan, I was there for 9 weeks. And I also had time, Nat's joining us. Yay.
Hey.
I'm going to add her to the feed. She's waving.
Hello.
Oh, what's that?
Hello.
Okay.
Sorry, I time difference. I was like, I've got an hour. Then I was like, oh my God, no. So
for everyone watching, I'm in Sydney, Brett's in Melbourne, and Nat's in Darwin. So
and she can't figure out the time difference yet.
So we've just had a chat on what a clinical trial is, and then I was explaining how, going through the experience with myself and being in NICU for so long, both in NICU and also the time that I spent on bed rest. And this is going back, so Elijah's now almost 21. So, there's a big time difference of being in the NICU, but not at one point was I ever approached about being in a trial at that time. And that's one of the important things of us, doing this network, that we want to keep advocating on why they're important. And that's going to be one of my questions to you, Brett. But at the same time, I don't know whether I would have said yes or no at the time, because I didn't really understand how important or what they were and things like that. So I guess my question is, one, why are they important? Like, I think intrinsically we know that research, like my babies were doing so well because other babies had said yes to research, but why they're important and what parents, I guess what they need to know to help them understand, like to turn that into a yes. And also, why do you think at the time it wasn't very popular to be asking parents, like, why wasn't I asked to be part of a trial? What's changed?
Yes, some really good questions there, Melinda. As my cat and my dog fight in the background, hopefully you can.
It's awesome. I love it.
So clinical research is critically important, and I guess neonatology as a profession, so that the intensive care of premature and sick babies is one of the youngest of all medical professions. Like, really what we do now and what we understand as neonatal intensive care has only really been around since the 1970s and 80s. And some of the treatments that we just hold as being standard of care, and some of those include antenatal corticosteroids and giving surfactant to babies, are really, they're even more recent. And this specialty is undergoing rapid change. It's amazing when you look back 30, 40, 50 years ago, how much progress we've made in terms of survival of premature and sick babies and for their outcomes. And many of you in the audience will be aware that we're now looking after smaller and smaller and more immature babies, right down to 23 and 22 weeks of gestation, which would have been unheard of a few decades ago. And much of that change has been down to clinical trials and advancements in technology. And I think this concept of doing research or clinical trials in little tiny babies and pregnant mothers, I think in some people that just generates a reaction of, well, how could we even do that? But you compare that to other specialties like cancer or heart disease, where this concept in the general public of doing research is just normal. People understand that, there have been massive advances in breast cancer survival because of the research that's been undertaken and the advances in technology and care. That's also true of tiny premature babies, but you can imagine that it's a bit different and very emotive when we go to the government or we go to ethics boards or we go to families and say, could we please do a clinical trial in you, pregnant mother, or in your sick little baby? You can imagine that in some people that elicits a response of, well, how can you even do that? But on the other hand, we know from our history that huge advances in the care of premature babies and sick babies have been made through clinical trials. In fact, that's one of the only ways that we can prove things are safe and effective. So from my perspective, and of course I'm incredibly biased because my career is trying to do clinical trials, I think that this is the only way forward. We need to be making advances, steady advances, to improve the outcomes for mothers and babies. And one of the ways to do that is through clinical trials. I think it's fair to say that in different hospitals around Australia or New Zealand or around the world, there are different levels of research going on. And I think that that's one of our challenges as a community, is to make sure that in every hospital there are the opportunities to take part in clinical research, because the more it's visible and the more we ask about it, I think the more success we will have, and parents and families will become more and more familiar with it.
I'm going to share a comment that's come through. So anyone that's watching, please feel free to ask a question or share a comment, because we're here. So Francis has said, I was asked to enter Orlando into a trial with oxygen. The way I had convinced myself to do it was that we had advanced so far because of other parents that had said yes before me.
Yeah, thanks, Francis. That's a common comment that we hear. And when parents are asked why they took part in research, some common responses are because I want to help other babies, and also because people have come before me and given my baby the benefit. And I don't want to come across as too biased again, but that is an absolutely true comment, Francis. All of those thousands of mothers and babies and families that took part in big clinical trials before your baby was born, therefore determines some of, if not all of, the care that Orlando received as standard care in the neonatal intensive care unit. And without those clinical trials, we wouldn't have known how best to treat Orlando and other babies born around the same time. But it's an ongoing process. We're never going to get to the end. We're never going to rest and say, oh, well, that's good enough. Survival's good enough. Outcomes are good enough. We know everything. It's simply not true. And anyway, it's driven by new discoveries, new drugs, new machines, whatever, that then need testing, that have promise to help little babies and families. Thanks, Francis.
Yeah. So what?
Sorry, Mel. I was just going to say that when the boys were in NICU, we've never been part of a clinical trial, but for me personally, clinical trials are so important because they just help answer the really important questions, and there's always, like you were saying, Brett, there's always this relentless pursuit or desire to do things better. And I think, clinical trials will hopefully always be around, because there'll always be a desire to kind of just, make treatments or medications or services better. And just,
that's absolutely right. And not only is that our desire, but I think it's essential. It's not good enough to rest on our laurels or to think we know best. And, this concept, society's changing. This concept in the past that doctors and nurses know how to do everything is partially true, in the sense that they can be acting at an excellent level and giving the best care that they know how to give and the best international care. But it's not true that they know the answers to everything. And in neonatology, we are very open about that, in the sense that, as I mentioned, we're a really young specialty in terms of other types of medicine, and there's a lot that we still need to find out. There's a lot that we still need to test, and there are massive advancements in technology over time that might be good things for babies. But we've got some big challenges compared to other types of research, because we are dealing with pregnant mums and babies. That's a very emotive thing, and the concept of doing no harm is super important. But also we've got some challenges of actually approaching families to be part of research. We've got the option of approaching families before a baby is even born. So that concept might be a mum who's at risk of having a premature baby or with a certain medical condition. And that's challenging because she might be, or the family might be in the middle of a really stressful time or about to have a baby. We've got babies being born who need immediate care, often as an emergency, often without much time to plan, and often after hours. And we have things that we want to know how they work, but we have to approach families in those first minutes or hours of days of life after their baby's born. And that's a really tricky time. And then through the NICU stay, when babies can be really sick and we come along and say, you know, we know your baby's really sick and we've got these two ways of doing things or a new treatment that might be helpful. What do you think about being in a clinical trial? And many in the audience may have been through that experience, and it's really tricky for us to get right, and we need the help of parents to get it right.
Mm-hmm. When you mention the help of parents, I'm just going to bring up a question that Grace has asked. How can parents get more involved in deciding what research is needed? And I think that's something that we've talked about we talk about a lot, don't we, Nat, in terms of how do parents have that voice and how are they able to, I guess exactly what Grace has asked, help decide what research is actually needed and matters to parents?
What a great question, Grace. I mean, in some ways you're already doing it because you're here in the audience on the NICU network, hearing about these issues and putting yourself forward as being interested in helping. Mel and Nat and I have discussed this at length yesterday. It is absolutely essential that parents and families and people with lived experience, which can include adults or teenagers that were born premature or born with other medical problems, they must be part of deciding what the important questions are and how we answer them. And there's a few ways in which they must. I think we'd all agree that it's essential for families to tell us what's important and how to plan research, the best we can for families. Excuse my dog. But also, he agrees, I think. Also,
does he want to come and join the live?
He is sort of, isn't he?
You should bring him over and show everybody.
He's a noisy one. And the other essential part of this is, from the other direction, the government and funding bodies, they're the people that give clinical researchers money to run trials or other researchers money to do research. They now tell us that it is essential. We already kind of knew that, but they're saying unless parents, families and people with lived experience are involved right from the start with planning trials and all the way through, you're not going to get the money, and we're not going to think it's as important as you do. It's not enough just to say, oh, it's a good idea, let's go and do it. It has to involve parents and people with lived experience. So how can you get involved? Well, Grace, getting in touch with the NICU Live team is a great way of doing it. Mel and Nat know a lot about what's going on. Keep your ear out for calls for help. So on Twitter and Facebook and other places, you will see advertising, if you like, for physicians to help out. That's not my dog that's barking, by the way. That's someone else's dog.
No, I think it might be mine as well.
Oh, there you go.
Oh, not mine, the neighbours.
It's the first time that's not mine.
So keep your ear out and or get in touch with Mel and Nat and them and find out what's going on and how to get involved.
Yeah, absolutely. And I think that's one of our, like Nat and I always talk about what would the future look like. And I'm interested in your opinion as a researcher, as a doctor. What would that look like? Like, would there end up being, I don't know, whether it's forums or that parents are part of, the big conferences we talk about, Pazance, and that happen every year, where we would actually be having parents in the room helping decide what research topics, to, I guess, put on the list and then prioritize them and say, these are the ones that matter. These are the outcomes that matter. That's what we're going to research. Because at the moment, like, I'd love to know from you, how do the questions, like when a grant round comes up and researchers start to put in their grants, how do they come up with the questions that they're going to ask?
Yeah, well, that's a great question, and you'll be pleased to know that there's a lot of that already going on, and Grace might be interested in taking part in some of these projects. Historically, the doctors and the scientists and the nurses used to decide what was important, and that's what would happen. And look, I still think in terms of the medical knowledge of what's important in the intensive care unit, I'm not doubting how important the doctors and the teams are in determining what needs doing, because we're the ones looking after the babies. We know the challenges we're having. We know what questions we need answered, and we know sometimes we have 2 or 3 or more treatments and we're not sure which one's the best. So we certainly know that part of it. But what we don't know is, and what we need help in, is prioritising which are the most important questions, what are the most important outcomes that families think are important, because they may be different to what we think, and help with prioritisation. Now, there have been many prioritisation exercises done between parents and consumers and clinicians. There was one from the UK just recently called a Delphi project, published by my friend Chris Vale and their team in the UK, which did exactly that, prioritised important research questions for preterm babies. And right at the moment, I'm part of a project for the most immature babies, or the most premature babies, led by a collaboration between Australia and New Zealand and the UK again. And this is looking specifically at the tiniest, sickest premature babies, that are those born before 25 weeks. And they're really a population of babies that is relatively new, in the sense that they've only even been around for the last 10 or 20 years. And now we're looking after babies born at 22 weeks in many centres around the world, which is really new and really new thing. And we need help in working out what's best for those babies. So again, we're doing a big project called a priority setting project, involving parents and consumers right from the start, and we're halfway through. And one of the next steps is to hold a big workshop with consumers and tell them where we've got to. These are the list of questions that the team has come up with. How do we rank them, and what do we think is most important to sort out? So certainly get in touch, and we can find a way to include anyone who's keen to be part of that.
Yeah, we need to share that. That's amazing.
Yeah, you definitely have to be a topic in its own, not an episode in its own, right? In the coming months.
Good idea. Yeah.
So what are the risks? Are there any risks for a parent to say yes to a trial? And one of the other questions I was asked last night when I was promoting as well was, what happens to my baby if a parent says no to their child being into a trial? Like, is there...
All right. So, let's talk about the risks.
My impression was there's fear both ways. There's fear of thinking, okay, my baby's going into, are they being experimented on? And then at the same time, if they really want me to be part of the trial and then I say no, what happens?
And this concept of risk in clinical trials is a really complex one, and one I've been thinking about a lot. Now, there are different types of clinical trials. So the first thing I would just remind us all is that if you have your baby who's unwell and in an intensive care unit, that baby will be treated in the way that that hospital and that doctor and that nurse believe is the best way to look after your baby. But that might be completely different, or subtly different, to how the same baby might be looked after in a different hospital, or by a different doctor, or by a different nurse. Now, that doesn't mean either of them are wrong. They're both probably following what they think is acceptable and best practice. But we may not know which treatment is best. So that's one of the really important concepts, is trying to work out, when there are different ways of doing it, which is the best way of doing it. That's called comparative effectiveness research. And the risk in a trial like that is hard to define, because if you go to hospital A, you get treatment A, and you go to hospital B, treatment B, and in the trial you get either treatment A or treatment B. And you could argue that there's not a lot of risk involved in trials like that. But then there are other trials where we have a new treatment or a new drug or some new way of doing things that hasn't been done in a clinical trial or even in standard practice before. Now, clearly, we don't just make stuff up, and we don't say, oh, I thought of a new drug, let's just start giving it to babies. It's gone through an incredibly rigorous process to even get to that point. And a trial doesn't even start without it going through human research ethics committees that really rigorously look at the trial, make sure the science is good, make sure the rationale and the reasons are good, that there's some potential chance of benefit that's important to patients and society, before we go to the point of asking families to be in a trial. So we're not making stuff up, and that's important to understand. But in a trial like I just described, where we've got a new drug or a new treatment, there has to be some risk involved in the sense that we wouldn't be doing the trial if we knew the answers. So if I had a drug that I already knew worked in 100% of babies and had no risk, I would just give it to all the babies. So clinical trials are about working out what the best way to do things is. Having said that, in most trials, there's half the patients who just get the standard care, so there's not any risk involved, and half that get the new treatment where there is the chance of benefit.
Yeah.
So it's really hard to weigh these things up, but when we are getting consent from families and from mothers, we do have to talk about the chances of benefit and the chances of risk. And that's really tricky. I'll just end by saying all clinical trials are very rigorously designed, hopefully with families and parents, and don't just come from nowhere. And also there's quite a lot of evidence that if you or your baby or any patient is in a clinical trial, overall they seem to do at least as well or better than patients or mothers or babies who are not in a clinical trial.
I've seen that.
Wow.
Yeah, that's really interesting phenomenon.
Yeah.
And it's something to do with perhaps the culture of the hospital or research focused, and people are open to new discoveries. Something to do with being watched more carefully, or having data where people are keeping a close eye on you and keeping a close eye out for any adverse effects. But there's that phenomenon that's really well known in the research community, that it seems to be a good thing on average to be in a clinical trial.
Yeah, I think that should be talked about a lot more for parents to have that awareness. And I guess from a researcher's point of view, it might be really difficult because you don't want to seem like coercive, like that you're pushing people into a trial. But to know that as a parent would definitely change the way I would have made decisions. Like to know that. I'm just going to pop up. Francis has made a comment as we're talking about this topic, saying, I guess it's very similar to each individual consultant that was on each week. They would always have a different point of view and change things around from the previous consultant.
Yeah, that's a well-known phenomenon as well, isn't it? And they're probably all acting, or definitely all acting, doing the best that they think they can do for your baby. And the reason that they're acting slightly differently is because there are more than one way to do things.
Yeah.
And gradually, as we go along, we need to work out which is the best way of doing things. There may be important differences in outcomes just by changing feeds in a different way, or changing oxygen in a different way, or changing breathing support, or whatever. There may be important differences that we need to find out. And Mel, I forgot to answer your question about what happens to my baby or me if we're not in a clinical trial. And the answer is, in almost all circumstances, you would receive the best standard care, which is you would get the care that always happens and everyone does their best. You just wouldn't be part of that clinical trial testing a new thing or comparing two new things. So it would default back to whatever the hospital or the doctor or the nurse normally does, which would be the best standard of care in any way. And parents take that differently. Some would say, oh, thank goodness, I just want to do what you always do because I'm sure you're doing your best. And that's true, but it doesn't mean it's the best treatment. We may not know. And others are the opposite. They say, well, I want to have a chance of getting this new treatment or this new outcome, or contribute to research no matter what, a little bit along the lines of what we heard earlier, that others have come before me and I'll take part so that the generation after me has the benefit, even if myself or my baby may not have direct benefit.
So can you give us some examples, and it might be trials that you're involved in or have been involved in that have really, like you mentioned surfactant before, and how that kind of advanced, or steroids for babies, and how that's really advanced healthcare. What's something that comes to mind for you that, really makes you think, wow, like this is really, we've gotten this answer, it's really made a difference?
Well, they were two great examples. And if I just talk about the steroid example, so for those of you not familiar with what we're talking about, mothers at risk of preterm birth, especially very preterm birth, and in Australia and New Zealand, generally before 35 weeks, if they're at risk of having a premature baby, they would be given some injections of what's called corticosteroid or steroid medication, and that helps to accelerate the maturation of the fetuses or the baby's lungs. And we know that when those steroids are given to babies that end up being born very premature. It increases survival and decreases some of the really important complications of preterm birth. And that the discovery of steroids came out of New Zealand, and I just maybe a good emphasise that Australia and New Zealand as a team have been at the forefront of advances in perinatal and neonatal medicine for decades now. We're absolutely at the in the world, and gradually the world's catching up, and steroids is a great example of that. So it came out of an observation in sheep by some scientists in New Zealand and quickly got translated in Australia and New Zealand into clinical practice, and then the rest of the world gradually followed. So steroids are one of the most amazing advances in neonatal medicine. They have pros and cons, but thankfully the cons are very minimum and the pros are very, very big for babies especially. But it's another good example of how we don't want to rest on our laurels. So we're still giving steroids the same way they were given 30 or 40 years ago, and they're working great. We know they're better than doing nothing, but there is still a lot of controversies. We don't know the exact timing, the exact dose, or the better type of steroid. Whilst we know what works, there might be better drugs or better ways of giving them. Right now in Australia and New Zealand, there are multiple large clinical trials going on again, recruiting mothers and babies to the trials to see if we can make it even better, and concentrating on some of the populations of mothers and babies that haven't been enrolled in trials before. I mentioned that very preterm babies, we know it's good. But what about babies born just a little bit premature, like 35 or 36, or even at full term, 37, 38 weeks of gestation? What about mothers having caesarean sections without much notice? What about mums who have diabetes or gestational diabetes? These are populations where we don't know the answer, and currently, again, Australia and New Zealand running big clinical trials to try and answer those questions.
Yeah. And I guess the other thing I wanted to lead into is, and I guess it's the point of our network as well, in terms of how parents can use their lived experience in helping with its research advocacy or changing clinical practice. And for myself, I guess the couple of examples that I feel like I've got sun's moving light on my face. A couple of examples that I think of, particularly on International Clinical Trials Day, is that a couple of years ago I was awarded the first Consumer Involvement Award with the Australian Clinical Trials Alliance. And that was because I was invited to be part of the Torpedo 3060 trial, which is looking at oxygen when a baby is delivered. And the important thing, I guess, about that was that I was able to use a parent voice, and I had the opportunity to present to the ethics committee. So, Brett, probably one of the most daunting things I've ever done was, travel up to Newcastle and enter the room and be asked about whether this is a good trial, and be that voice for all parents. In terms of the consent process with the trial, because it's a waiver of consent trial. But I guess it was a real big, eye-opener for me in terms of that the relationship that parents can have with researchers can be meaningful and can have so much value to be able to assist what trials then go and proceed into the NICU. And for myself, and Nat, you might be able to speak to it too, I can think of the top of my head, the different trials that are making an impact to families, but also to myself in terms of being able to acknowledge the journey. So one of the big trials that I had so much pleasure being part of is the FICARE trial, about family integrated, which stands for family integrated care, but really looking at ways that we can make parent involvement more than feeling like visitors, because sometimes, you feel so helpless. What can I do other than, pump milk and be there every day, but looking at how we can really integrate families into that. And one of the things that we spoke about yesterday, and I'd love to I know we're going to do a whole lot of different episodes on all the different topics, but we talked about like the value of kangaroo care. So even though which is something really simple. So two things come to mind. One, kangaroo care, which is mums and dads and being able to actually have that skin hold on baby and doing research about why there's benefits around that. That's not a big, scary, new intervention, experimental kind of treatment. And the other one that comes to mind is the delayed cord clamping, that when a baby's born, rather than rush in to clamp the cord, we just wait a minute and let Mother Nature assist. So I guess I'm just trying to, there's so many different ways that we can get questions answered that don't feel so scary, but also to have that parental involvement, I think is absolutely incredible. And it's been amazing to me to see that there's so many different ways that we can help in the unit to have better outcomes for babies. Did you want to say something to that, Nat?
Oh, I just totally agree with you. I think it's really exciting, and things like the recent trials, like the delayed cord clamping, is just like, wow, this is amazing when you kind of see kind of grasp what it's about and the its potential to save thousands and thousands of lives. Like it's amazing. Like,
and they're two really good examples really of how we've sort of had this history through neonatal intensive care of wanting to do lots of things, separating mothers and babies or families and babies to go off to the unit and do things, and how we've come full circle now. And I must say, this is not for every baby, because there are some really sick babies that need emergency intensive care. But we've come full circle now back to delaying cord clamping, which was the way it was always done before medical intervention. Well, animals wait till they chew their cord off a few hours or minutes after the birth. Delayed cord clamping was standard until medical intervention used to come along and cut the cord. If you just had your baby at home, wait till it all happens on its own. So we've come full circle and shown the benefits of really doing less in a way, more centered care, as you put it, Mel. So delayed cord clamping is a good example, and the kangaroo care is another one. And we could spend a whole episode on this.
But we are going to have to do it in other episodes.
It's been brought home by a big trial that was recently completed and published in lower and middle income countries. So this is not countries like Australia. This is through Asia and India and Africa, showing that in fact, even for little premature babies, straight after the birth, putting them on the mum, or if the mum's not available, on a relative, and caring for the baby in that kangaroo care position, where there are less resources and higher risk of infection and that sort of thing, actually increases survival, reduces infection, and has huge benefits just from that one simple intervention and keeping the baby, as Francis says, Mother Nature intended. And again, to reiterate, I don't want us thinking that that's always going to be the case, and your baby's born at 22 weeks and needs a whole heap of stuff done. There are limits to what we can currently manage, but believe it or not, we are still trying to find ways to maximise that contact and to delayed cord clamping. One of the big topics currently is, can we actually perform the resuscitation and the stabilisation of very sick newborn babies using some sort of a bench or a surface right near the mother who's just birthed with the cord intact? And those trials are going on now to tell us whether that's something we need to be doing.
Do you know how amazing that would be? Because I remember delivering Dylan, and it was 4 days. I was in labour for 4 days, so I was absolutely exhausted at that point when he was delivered. But I just remember, the relief, because I wasn't in pain anymore, seeing him for a really split second, and then he was gone. It would have absolutely changed my experience, I think, if I had more of that moment with him in that time. And this is the side I don't think people think of, that's what's included in research. It is all of those.
This is where we need your voices, and I'm sorry that happened. We're definitely getting better at it, Mel. I mean, this concept of a birthday cuddle or a cuddle in the delivery room is one that most hospitals have really taken up. And we try, I can only speak perhaps for ourselves, but we try very hard, unless there is the need to really emergently whisk the baby off and there's things going on that require intensive care. We try really hard to get some contact, even if it's inside an incubator, but hopefully with a proper cuddle in the delivery room. So we're certainly trying hard, but this is why we need parents' voices to tell us how we can be better.
Yeah, because I remember being in a discussion about the delayed cord clamping, and to wait a minute, and a minute can feel like a long time when you're watching the clock. A minute can feel like a long time, and a healthcare professional said, "Well, what happens in that minute?" And I kind of put my hand up and said, "Well, in that minute, let the parents be introduced to their baby, let mum hold the baby, or let dad." One of the biggest things dad always talk about is cutting the cord. So maybe that's the time that you can teach him, even though it's really scary and you don't know where things are going. But yeah, I like to use that opportunity. But there's so much that we can talk about on each individual topic, which is incredible.
I might end with a quick story about something that just about had all the doctors and nurses in tears a few weeks ago, which was the birth of triplets, where they came one after the other and all had delayed cord clamping. And there's the parents, with these babies being held up one after the other while they had delayed cord clamping. It was really fun to be part of.
Yeah.
Can I ask you quickly, and I know we'll wrap up soon, but where does your passion come from? Like, I'm fascinated. Like, what made you want to be a neonatologist, to look after babies and families, and then also to be passionate about research and make that change?
Why wouldn't you want to be a neonatologist? That's what I mean. Okay, so firstly, some people are drawn to pediatrics and looking after kids and babies, and I was one of those people. And experiences of working in the children's hospitals and things, and watching kids get better, because most kids get better is amazing. And yes, it's one of those jobs that has its ups and downs, but what could be better than making a difference right from the start, taking a baby or a sick mum or a really sick baby who otherwise might not survive or who might have serious complications, and turning that around, and the opportunity to end up with a child who grows up to an adult and leads a long and happy life where otherwise they might not have. It's pretty amazing, and I think we're all really blessed to be part of it.
I can hear your prems in the background, Nat.
Oh yeah, we're about to go swimming lessons, so watch out. Yes, but they owe everything to your profession. I mean, they wouldn't be around without the amazing care they received from the doctors and nurses at Melbourne.
And I think as parents, like, you don't, like I know, and we've spoken about this too, Nat, that you just in a haze. There's such a. Does he want to come and say hello?
Oh no, it's right. He's outside. Bye bye. Bye bye.
Enjoy swimming. Yeah, like you're in this cocoon and this haze, and it's not until you leave and you kind of leave that fog that you just really reflect on what you've gone through. And isn't that right, Nat? Like you've said that you were kind of, for a few years, it was just
in shell shock for years, really. Yeah, probably the first 3 years. But the time, and reflection, just so grateful for everything.
Well, thank you to you both and to Emma for, starting up networks like this is exactly what's needed. It gives everyone a voice. It gives the opportunity to hear about what's going on in the NICU, to demystify some of those things that people are wondering about, and to hear about how you can get involved. And you both know that I'm already sort of hitting you up to be part of clinical trials that are ongoing, and this is critically important. There's plenty of room for others to contribute. In fact, we really need it. So get in touch with the NICU Live team or with the other organisations around the various states and territories of Australia and New Zealand. Life's Little Treasures, Miracle Babies. There are many more. So put your hand up, get involved, and we'd love to have you help us prioritise and do the best we can for the next generation of babies.
Absolutely. I think that's a perfect way to wrap up. I know as a parent, it's an absolute honour and a privilege. Like every time I get asked to be part of a project, or, to be able to include other parents into a project, it's very humbling as a parent to come back, and there is a lot of healing. But thank you so much. We've got Francis has said, thanks for a great chat this morning.
Lovely.
We're getting some beautiful comments. Tina has shared, love your work, ladies. You too, Brett. Well, thank you everybody for joining us on International Clinical Trials Day. It's definitely a day that matters a lot to the network, because that's where our passion lies in trying to use our lived experience and what we've gone through, including other parents and even babies who are growing up that were born prem or spent time in the NICU, using what they know to be able to give back in advanced healthcare. So thank you so much, Brett. I know we had a big chat yesterday that you were going to be a regular on our show, and that there's so many different topics to talk about.
Yeah, looking forward to it. And please, for those out there in the audience, send in your questions or the topics that you really want to hear about, and we'll make sure that we discuss those going forward. So thanks for having me.
Awesome. Thanks, you, everybody. Enjoy your Sunday, or your Saturday, sorry, your weekend. It's beautiful. I don't know, how's your day there, Nat? Are you having a beautiful day?
Yeah, perfect.
Darwin is always amazing. All right. Thank you, everybody.
Right. See you guys. Da, 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 da. That's a wrap on another episode of the NICU Live Network. Thanks for joining us today. To stay connected, please make sure you're following us on social media and have joined our Facebook group.
And if you found value in this episode, please share, like, or comment.
We'll see you on the next episode.